Hello, everyone, and welcome to today's webinar. We are truly appreciative of you guys attending. A few things to note. For all participants will be muted upon entry and videos turned off. For technical assistance, please use the chat box. You will also receive an email in approximately 3 months requesting feedback/impact on this presentation. And we would also like for you to visit www.ncdas.org/training to view other training opportunities that NCED offers. I'll now go ahead and introduce today's speaker, Ms. Brittany Davis. Ms. Brittany Davis is a senior dental student at Columbia University College of Dental Medicine. She received her BE in chemical engineering at Vanderbilt University and worked as a software consultant before pursuing dentistry. Throughout her 4 years in dental school, Brittany focused her studies on an interprofessional model for patient care. She leads a research group studying dentists' role in identification and symptomatic management of eating disorders. She is collaborating with the Academy for Eating Disorders to incorporate dental guidelines into a medical standards guide. And she serves as a member of the Interprofessional National Dental Association, where she works alongside a multidisciplinary healthcare team to address modern barriers to comprehensive patient care. Brittany has been accepted into Emory University's combined medical school and oral and maxillofacial surgery residency program. Over the next 6 years, she will receive her MD degree from Emory, become a credentialed surgical subspecialist, and continue expanding her vision toward teams-based patient care. I'll now turn things over to Ms. Brittany Davis.
Hello, everyone, and thank you so much for donating your time to be here tonight. I really appreciate it. So just to move forward with things, today we're going to be speaking about oral health, and the title of this presentation is Preservation of Oral Health and Eating Disorders, an Essential Guide for Health Professionals. And again, my name is Brittany Davis, and I am from Columbia University, graduating in about a month. So to give some background as to why this topic is even important, eating disorders are very important and severe. They're largely prevalent. Some studies say upwards of 1% of Americans have been or could be diagnosed with anorexia nervosa, and 2% could be diagnosed with bulimia nervosa. These percentages encompass a whole wide range of people. It's not necessarily just young teens. It could be older adults, men and women. And if anything, these numbers are likely still underestimated. And a failure to treat these eating disorders can cause some pretty critical consequences. It leads to some serious systemic health conditions. It can lead to irreversible bodily harm. And unfortunately, it can lead to death. And it does have a mortality rate that's pretty high when compared to other psychological disorders. And so research has found that early intervention is the single most important factor in terms of having a positive long-term outcome for this population. So now the reason why dentists getting involved is so important is because, number one, dentists see a wide range of patients, and that could be with our pediatric dentists who see kids, orthodontists who classically see teenagers, general dentists see people of all ages, prosthodontists may be working with an older population, oral surgeons, again, could be any age group, and classically that 17 to 18-year-old age group who get their wisdom teeth out. So we really can see people across all ages. And also we're one of the only health providers that are giving a comprehensive oral exam. And research has shown time and again that there are quite a number of symptoms that present through eating disorders and present through the mouth. So, it's really up to us to catch those oral symptoms. And again, dentists, we have regular recall. Ideally, we like to see patients every 6 months, potentially more, which gives a great opportunity to really catch these early symptoms. And hopefully we're developing trusting relationships with our patients, having worked with them for potentially years in and out. And it has been acknowledged that a dentist may be the first provider to encounter an undiagnosed eating disorder. So it really is our responsibility to kind of be in tune to these symptoms and speak out when we see something. And just for some basic background, the DSM-5 diagnostic criteria for both anorexia and bulimia. For anorexia, it can be defined as the restriction of energy intake causing a significantly low body weight, an intense fear of gaining weight, and an excessive influence of your weight or shape influencing your self-evaluation. And anorexias can be broken into restricting type versus the binge eating and purging type. And then on the other end of the spectrum, we have bulimia, which is known as having recurrent episodes of binge eating, followed by recurrent compensatory behaviors to prevent weight gain. And that can that can come in many different forms, whether that's vomiting, the improper use of laxatives or diuretics, or fasting. And again, just like anorexia, there's this excessive influence of the way your body weighs or its shape in the way that you self-evaluate. And of course, it's a large spectrum. There are people who fall in between and may not meet the exact criteria for just one or the other. So again, there's plenty of people to watch out for. And so for today's webinar, we've got three pretty basic learning objectives. By the end of this, the hope is that you'll be able to describe the oral signs and symptoms associated with eating disorders, that you will be able to compare treatment and intervention options for patients who are showing these symptoms, and finally, be able to prepare some risk reduction strategies for patients who are experiencing active or relapsing episodes of disordered eating. So to start, I would like to talk about acid erosion, and that's probably one of the most classic oral symptoms that anybody thinks about regarding eating disorders and our oral health. And acid erosion comes in two primary forms: intrinsic acid erosion and extrinsic erosion. So for some basic anatomy, our teeth is made up of several layers. Our outer layer is called enamel. Just under that is the dentin layer. And then beneath all that is the pulp chamber, which carries our blood vessels and our nerve supply. So in terms of enamel, it has a critical pH of 5.5. So any pH that begins to dip lower than that or becomes more acidic is when the enamel erosion begins. At that point, it no longer can maintain its integrity. And at the incisal edge of the tooth, when we get that enamel thinning, that will appear as a translucent edge. And more so in the body of the tooth, when we get that enamel thinning, we'll see it as yellow, the color yellow coming through. And that's because dentin underneath enamel is yellow. And so we'll start to see its color. And here's some examples of what that could look like. On the left, we see that very thin translucent enamel at the incisal edge. And on the right side, we see some examples of that pronounced yellow color coming through as the enamel at the body of the tooth is being eroded away. So first, talking about intrinsic acid erosion, that's defined as gastric acid that is contacting the teeth, and that can be due to self-induced vomiting. However, it can also be due to other diseases such as gastroesophageal reflux disease. So it does make it a bit different to differentiate between the two, which is something to really note in the clinic. And intrinsic acid erosion is primarily noted for its effect on the palatal surfaces of the maxillary anterior teeth. So all that to say, it's on the inside surface next to our tongue of our upper arch of our front teeth is where we will really see that erosion coming through. And then in later stages, we'll also start to see it affect the occlusal surfaces, which are the biting surfaces of both the maxillary and mandibular posterior teeth. And there's been a term given specifically to this type of erosion called perimylolysis, and it's characterized by this smooth, glossy appearance, free of staining. It's very classic for any sort of intrinsic acid erosion. And so here's one example where we can see on the palatal surface, we've got some erosion going on, pretty smooth and glossy. Another more pronounced example, we can see even more severe erosion, particularly on these posteriors. And then here we can, even more clearly see that erosion, so much so that we can see physically that DEJ, the dentinal enamel junction, where this yellow body is the dentin and this white outer layer is the enamel. And the acid is really chewed right through that protective enamel. Now, here's an interesting picture because intrinsic acid erosion is really characterized by this smooth, glossy erosion that's free of staining. So if you see teeth that have been worn down by erosion that are beginning to stain, it actually can hint that the behaviors have begun to stop, and that potentially this patient may not be in a very active period where they are binging and purging or vomiting. And for that reason, the teeth have now been allowed to stain. And then finally, this is actually a case of GERD, which looks very similar to the acid erosion we see with reflux, self-induced vomiting. However, this patient in particular sleeps on their left side. And so for that and they have nocturnal reflux primarily, which is why we see erosion only affecting the one side. So just very small details we can use to try to get a better picture of what's going on with our patients. Next, moving on to extrinsic acid erosion. Extrinsic acid erosion means the consumption of acidic foods or drinks. So that could be anything such as sports drinks, diet soda, raw citrus fruits, anything like that. And this is more so seen with anorexia nervosa, bringing in foods that are very low calorie to prevent oneself from intaking too many calories. And with extrinsic acid erosion, the pattern is going to be on the buccal or outer surface, the labial surface of the occlusal teeth, and it has a more dished out appearance. So it's pretty distinct from the intrinsic acid erosion, which we saw on the inner surfaces of our teeth, particularly our upper arch, those front teeth. And so some examples here we have on the outer surface, this dished out appearance of these posterior teeth. And again, another great example, you can see this dished out appearance from the extrinsic acid, so acids that we're consuming. And finally, one more picture. So now the clinical correlation to all this. First, these sort of lesions can be seen anywhere between 6 months after the behavior has begun, upwards of 2 years into the behavior. 6 months, just very severe behavior, and 2 years being more closer to the average, according to the research. And after we've had this sort of erosion, the patient is going to be very sensitive to hot, cold, touch, and air. It can even get to a point where it's so severe that the patient will complain of sensitivity with just brushing their teeth. Even that amount of pressure will be painful for them. And with erosion, we're eroding away the surfaces of our teeth. So over time, it's going to become shorter. And that has a handful of consequences by itself. Number one, it may lead to something that we call an anterior open bite. When you close your mouth all the way, your front teeth still aren't in contact. There's a little bit of a space. We can see a compensatory eruption of the teeth opposite those that have been eroded away to come and try to meet their partners. A loss of video means that there any sort of compensatory eruption and overall the other sort of look. And then also we will see high seating restoration margins. meaning that the tooth itself will be eroding away, but the amalgam filling or the composite filling will be standing strong, unaffected by the acid, and it will be a noticeable difference. They'll no longer be flush. And of course, this causes poor aesthetics for the patient. And so some examples of an anterior open bite. Here, the patient is closing all the way. We can see that their posteriors are in maximum intercuspation, but there is still this space where their front teeth aren't quite coming together. And then in compensatory eruption. So I give this picture as an example of what our normal smile line should look like. On top here, we see that the upper teeth kind of follow the shape of the lower lip in the shape of a smile. Here on the lower side, we see that these teeth have had severe erosion, and so her lower teeth have erupted even more so to meet them. However, now her smile line is almost in the shape of a frown, opposite of her lip smile line. If there is no compensatory eruption, then we may see what we call a loss of vertical dimension of occlusion. In the most severe case, this is kind of what we see with patients who wear dentures. When they take their dentures out, you see that their maxilla and their mandible come even closer in relation to each other. And that is possible to develop with very severe eating disorders, and often more so in an older population who's suffering with an eating disorder. And finally, this is what high restoration margins might look like. So the tooth structure itself, and particularly here, is eroding away, but that silver filling is just standing just as high as when it was placed. So next, I would like to talk about xerostomia, which is a fancy word for low salivary flow. And before I can get too much into that, I have to explain how caries develop in the first place. So first, we have what we call a pellicle formation. Caries develop due to bacteria that are colonizing our tooth surface. They kind of stick along the surface in what we call a pellicle, and more bacteria of different types start to accumulate and add on to that pellicle and cause plaque formation as they start to build up and clump together and colonize. And then eventually those bacteria, they start to feed off of carbohydrates. So they eat what we eat. They feed off of carbs and they secrete acid in return. And that acid that they secrete is then what we call a cavity or caries. And that acid is what chews away into our tooth, and that's when a cavity needs to be filled. So saliva is just abundantly important for trying to stop the process. Saliva has pretty cool functions, the first of which being bacterial clearance. Within our saliva, we have these things called glycoproteins that can cause bacteria to clump together and be washed away as we swallow, be washed away with our saliva. We have buffering acids in our saliva. Things like bicarbonate is a huge one, and it helps to neutralize the acids that the bacteria are secreting to help promote a healthy space that our teeth can survive within and not deteriorate. We have plenty of antimicrobial agents like lactoferrin or immunoglobulin A. All these things come together to help either kill bacteria or to neutralize them or to prevent them from rapidly spreading. And finally, within our saliva, we have nutrients for remineralization. So things like phosphate ions, zinc, fluoride, all of these ions actually incorporate into our tooth structure and help rebuild its foundation. So even if we have an incipient cavity, a very small lesion, before we hit the point of no return, there is a point where we can reincorporate some of these ions into our tooth structure and rebuild the foundation so that it's strong again and it is not overcome by cavitated cavity. And so all that to say is if somebody's experiencing low saliva flow, they're losing out on a whole lot of benefits to prevent cavity formation. So there There are quite a number of causes for low saliva flow. Some of it can be due to the salivary gland function, particularly if somebody is engaging in binging and purging habits. You may see some changed function in their parotid gland, and there may be less production of saliva due to that. Also, with SSRI medications, selective serotonin reuptake inhibitors, it's an antidepressant that is commonly prescribed. It has a known side effect of reducing salivary flow. So that's definitely a big one to look out for in this patient population who very likely could be on an SSRI that could be aggravating that low saliva flow. And then also, simple dehydration can really influence the flow rate. Dehydration can come from anything such as fasting, self-induced vomiting, intensive exercise, abuse of laxatives, and abuse of diuretics. All these together would produce a low saliva flow. And now just transitioning to a few other oral symptoms that are more commonly seen, parotid hypertrophy. So that is the recurrent non-inflammatory gland enlargement of the parotid gland. And based upon where it's located, it gives this wide sort of square appearance to the mandible. And the hypertrophy will occur roughly 2 to 6 days following a binge purge cycle. The interesting thing about it is that the swelling is soft to palpation and it's painless to the patient. And numbers have been sort of all over the place in the research, but it's kind of agreed upon that there's about a 10 to 50% prevalence of parotid hypertrophy along with a cycle of purging habits. And in the early stages, this swelling is intermittent. It will come and it'll go. It's reversible. But in the later stages, if the habits are prolonged for a great deal of time, it's possible that there may be a permanent deformation of that swelling, with only surgical correction being the option at that point. So it's very important to stress to our patients that, if they're able to kind of curtail these habits, this swelling is something that does not have to last forever. It potentially is reversible on its own. And here's just a picture of the classic look. We've got that square sort of bulge at the angle of the mandible. And again, that's going to be about 2 to 6 days following a binge purge cycle. And then just some more examples. It can be unilateral or it can be bilateral. And this is where the parotid gland is located, which explains why it's such a classic presentation. Now, we also know that patients with eating disorders often present with nutritional deficiencies as well. And there are quite a number of nutrients that affect the mouth. So zinc and copper both aid in preventing enamel acid solubility. So being deficient in either of those will lead to easier erosion. Vitamin D deficiency has been linked to worse outcomes with periodontitis and gingival inflammation. Vitamin A is pretty critical in maintaining the salivary gland. So a deficiency in vitamin A can lead to salivary gland atrophy, which then leads to a low salivary flow and all those other sort of things that comes with it that we spoke about. And then the B vitamins, a deficiency in those, you can see a burning mouth. We call it burning mouth or burning tongue syndrome, cracked lips, oral ulcers, angular cheilitis, and sore throat. A calcium deficiency. As we all know, calcium is very important for the integrity of our bone, and the alveolar bone supporting our teeth is included in that. An iron deficiency often leads to what we call pica, and a classic sign of pica is this want to chew ice, which is not at all great for our teeth. And then finally, vitamin C. Vitamin C deficiency is pretty rare in this day and age. However, if it were to occur in some very severe circumstance, then it would compromise our periodontal ligament health, which is the ligaments that connect our teeth to the bone. You would see gingivitis and spontaneous bleeding. And for just the last few pictures, this is what angular cheilitis looks like. It's this red cracked appearance at the corners of the mouth. It's certainly pretty painful, so a deficiency in B vitamins could lead to this. Nutritional deficiencies overall oftentimes can lead to oral candidiasis, which can present in many different ways. On the left here, you see what would be called medial rhomboid glossitis, which is still oral candidiasis with this classic sort of red bald spot in the middle. And oral candidiasis is this white film that can be scraped off. That's kind of how you distinguish it from some other lesions that have a white coating on the tongue. So now goals for dental intervention. Overall, as dentists, we want to reduce the frequency of the oral acid exposure to these patients. We want to enhance their salivary flow. We want to try and neutralize the acids that do interact in their mouth. We want to support enamel resistance to demineralization. We want to minimize abrasive oral hygiene habits, preserve remaining tooth structure, and delay complex restorative treatment until the habit has resolved. So in-office considerations, fluoride is certainly our friend here. There's many different ways to apply fluoride, whether that's an in-office topical or prescription daily rinse that the patient can take home, or creating custom trays so the patient can apply a fluoride gel at home. And all of these will help promote the remineralization of tooth structure. We can also make use of desensitizing agents like Gluma to help with just the day-to-day pain and sensitivity that patients are feeling with eroded tooth structure. Also, we can make use of temporary restorations and using conservative treatment, again, because complex permanent treatment is not likely to hold up for very long if the habits are still sustained and going strong. So that's why we want to start slow. So conservative treatments could be anything like composite buildups, direct or indirect veneers, bonded onlays, things like that to kind of boost the patient's confidence in seeing some improvement to their oral aesthetics before moving on to the more treatment. And then also we can consider things like prescription artificial saliva or over-the-counter artificial saliva to help, again, with that low flow. And then likely we want to consider more frequent recall for these patients. So maybe a 3 to 4 month recall as opposed to every 6 months, just to really keep track of how their oral health is doing during this time. And then in terms of harm reduction that we can suggest to our patients, first off, we can suggest that they decrease the amount of acidic food and drink that they intake. They may not be aware how severe of an effect it's having. We can also recommend that they do drink acidic drinks with a straw to try to help bypass some of that liquid from their teeth, kind of just straight to the back of their throat. For those who participate in self-induced vomiting habits, we can really recommend that they rinse with some sort of water or alkaline solution after vomiting. And more importantly is to refrain from brushing for at least 30 minutes. It feels pretty natural to want to brush right after. However, our teeth are really sensitive at this point where they've just had this acid attack, and brushing may make the problem even worse and be abrasive. So just rinsing with water and alkaline solution, and then refraining from brushing, and then sipping water throughout the day, helping with the low flow saliva just to keep some sort of fluids kind of moving and washing over our mouths. Minimizing carbohydrate heavy snacking or binges. Again, kind of going back to the fact that these carcinogenic bacteria feed off of carbohydrates. So the more we can minimize the amount of carbs that we're bringing in, the more we can kind of fend off that risk of caries. And then a sugar-free gum is an easy way to stimulate saliva flow. And then, of course, we want to use soft bristled toothbrushes with gentle circular motions. We want to stay away from those hard bristles, even though it may feel like it's getting off all the grit. It can also be brushing off layers of your enamel as well. So soft bristles only, circular motions instead of these repetitive horizontal motions. And of course, we always want to recommend to our patients that they floss daily as well. So now here are some of my references. And with that, I can open up the floor to any questions anybody may have.
So thank you so much, Ms. Davis, for the presentation today. As she mentioned, we will begin opening up for question and answers. I'll ask for you to type your question and answers within the Q&A box. But there are a few things that I also would like for you to know at the end of this presentation conclusion, you will receive the evaluation via email for you to complete. And we will also be sending a copy of these slides to you on Monday. A recording of this webinar will also be available on the NCEAD Training Center within 1 week from today for anyone that would like to refer anyone to this presentation or access the presentation again. Brittany, they are also asking if it's possible for you to go back to your references slide.
Absolutely.
And just leave those up for people. So thank you all, and I will begin reading the first question. Okay, so we have the references up again. Do we have any additional questions in addition to the request for the references?
And in terms of references, there are far more than this. So if anybody really is interested, I would love to give you a more comprehensive list of some pretty neat articles that are out there.
Okay. We have some people that are saying great webinar and thank you. Do we have any additional questions at this time? Okay. Brittany, our next question is, at what point can cosmetic work start?
So essentially the research, and nothing is very set in stone, but the goal is to kind of hold off on cosmetic work until particularly the binging and purging habit has subsided. The fear being that cosmetic work done while that's still ongoing may fail. So if that patient becomes a little bit more stable, at that point, by all means, even if it's just temporary cosmetic work to begin with, just to bump up their, just their ego and make them feel a little bit better, that even may help in terms of their just like overall resolve to continue to do better, just having a little bit of momentum. So maybe a little bit of temporary cosmetic work, and then for the final stuff, once those habits have subsided a little bit.
Okay, thank you. The next question is, what do you think could be the role of a nutritionist in the dental setting?
Oh, that's a great question. I think there's a lot of opportunity for nutritionists to work with dentists because, a lot of our oral health is dependent upon what we put in. So kind of like we spoke about, these acidic food and drinks that we're intaking, the types of nutrients that we're bringing in, so like carbohydrates, and if that's the primary source of our food, that's going to increase our risk of caries. So, and I mean, even beyond that, our risk of caries is due to not only what we eat, but how frequently we snack. So if we eat just maybe 3 days, that's better than 5 or 6 tiny snacks throughout the day. So goodness, I think a nutritionist kind of alongside a dentist to explain the why behind why those little changes matter and what they do would be so important.
Thank you. The next question is, what are the 3 basic recommendations to achieve good oral hygiene?
So 3 basic recommendations off the top of my head, I would say number 1, go to your dentist regularly. That's without a doubt. Just always make sure that you're being checked by a professional and that things are going well. Number 2, maintain those daily habits like brushing and flossing, daily, not skipping every couple days, but really trying to be religious about it. And number three, I would say doing those habits well. It's kind of difficult to know how to floss the proper way, but doing so makes all the difference, or how to brush the proper way. But that really could be the difference between kind of getting caries under control versus continually every couple years still having another cavity and another cavity.
Thank you. And then we have another question. What are dentists trained regarding talking to the patient about their eating disorder and their behavior? So many of them that I've spoken to feel very uncomfortable addressing the eating disorder.
Yeah, so the unfortunate news is that we don't receive much training at all regarding that sort of hard discussion, which is why we see in practice, dentists feel pretty uncomfortable. It is a difficult conversation, particularly when you get into the matter of maybe speaking to a minor. How do you do that when with their parents involved? It's tough, but I think as dental professionals, it also is, our responsibility to take on some tough and not so nice conversations. Um, so all that to say, the training in regards to how to have that conversation is pretty minimal as of right now, but is something that I, in particular, have my sights set on to try to make some sort of basic guidelines or just template to help us all ease into that.
Thank you. Are there any additional questions? We've read all of the questions posed at this time. I'll give another minute or so to see if there are any additional questions from anyone else in the audience. We have another question, it seems. Okay. Can a dentist save a loose tooth?
Sure, it depends. It depends on why the tooth is loose, maybe for how long it's been loose, a whole bunch of different factors. But it being loose alone does not mean that there's no hope. So certainly there's a possibility, um, without a doubt. It just depends on quite a few other factors.
Okay, great. And thank you for that. There's an attendee that stated that some of the eating disorder training for dentists is done at the Alliance for Eating Disorders Awareness. Okay, Brittany, I'll give another minute again for any other questions at this time, but is there any additional research or information that you think is pertinent to the field of dentistry regarding eating disorders that you'd like to share with the audience?
Oh, so there's quite a bit of other information out there. I tried to present what's kind of the most verified as of yet, but there is a lot less verified information that still requires more research before it can kind of be definitively said. So, for example, it's still up in the air whether or not eating disorders um, does lead to higher rates of periodontitis or not. That's a pretty large one that's up for debate still. There are other symptoms such as TMD, temporal mandibular disorders, whether there's a significant correlation between those two, potentially. I wouldn't be able to say for certain just yet. And then that sort of one repeat, but with quite a number of other symptoms. So um, I guess all that to say is that eating disorders really affect our oral health far more extensively than we may realize. And that just adds to why it's so important for dentists to get involved in this space and to, really try our best to intervene early, to catch those that may have these symptoms and, refer them and get them treated sooner than later because it certainly has a pretty large impact on their oral and overall health.
Great, thank you for that. We also had a few additional questions that came in. So the first one asks, eating disorders seem to often have a behavioral health component, and as dentists, we tend to address the fixing aspect. Acknowledging the movement of integrating oral health, behavioral health, and primary care level, the interprofessional organization that was mentioned at the beginning of your talk, can you share the name once again?
Oh, are you talking about the Academy for Eating Disorders?
I assume they said it was mentioned at the interprofessional organization that was mentioned at the beginning of your talk. Can you share the name once again? And
Yeah, so there's, I guess, several groups I'm working with that are trying to integrate oral health alongside the rest of medicine. So the Academy for Eating Disorders is one. There's also one called the National Dental Association that has this interprofessional um, sort of just group that we have going on where we're speaking with dentists, physicians, speech pathologists. It's kind of like a small uh, sort of new group we have going through that, like a new initiative that just began maybe a couple years ago.
also, Brittany, the one that's mentioned in your bio, the Interprofessional National Dental Association, I
Yeah,
think maybe another one that they're referencing.
yeah.
The next question asks, charcoal black toothpaste or versus regular toothpaste, the debate.
The age-old question. So I'm going to say I'm a fan of regular toothpaste, only because the charcoal toothpaste. Not to say that maybe just every once in a while using it is okay, because it will brush off some stains, but it can be a bit abrasive. So using it as a regular toothpaste could really take a toll on the enamel. So I would say don't make it your daily driver, but every once in a while shouldn't hurt. But I personally stick to regular toothpaste.
Thank you. The next question asks, having treated many dental phobic patients along with those with eating disorders in my past, I wish I had other health professionals available to work with in private practice, setting to take a whole patient approach. Do you have any feedback regarding that?
It's difficult. Dental phobic patients, I really feel for them. I feel like it makes a lot of sense to be afraid of the dentist. You're working in such an intimate space, very close to what could be a stranger. Maybe you're already in pain, and you're worried that what they're going to do to you is going to cause more pain. I think so. I certainly think that having other health professionals all together to help would be the ideal. But I guess in the here and now, when it's normally just one on one, it really just comes down to being very slow and patient with these types of patients, and maybe just setting small goals from the beginning. Maybe not even having a goal of treating something the very first visit, but just kind of talking and hearing out why they're afraid and what can be done to make them a little bit less afraid. Um, just trying to regain their trust and not judging them for their fear.
Great, thank you for that, Brittany. The next person stated, FYI, Columbia University was one of only 3 institutions that started in this interprofessional space back in the 1980s with a program called Health of the Public Grant. Great presentation, Brittany. I don't know if you want to expound a little bit on the Health of the Public Grant and what you know about it.
I will say I don't know about it, but it looks like I've got some homework to do tonight. So
Mhm.
I do appreciate that you brought that up.
Okay, thank you. That seems to conclude any questions that we have at this time. Once again, Brittany, I don't know if there's anything else that you may want to share with the group in terms of maybe additional articles that they might want to look up on information regarding eating disorders within the field of dentistry. Any one of the references that you might want to have them focus a little bit more on. I'll give you that opportunity at this time.
Ooh, so there are a handful that I would love to pass out. Will there be any opportunity to kind of send out in like a mass email a few articles? I have some that aren't listed on this reference sheet that I would like to put together and distribute for those who'd like to read a little bit more.
Yes, there is an opportunity for us to send out references and the PowerPoint presentation in a mass email to everyone, and we can collate all those documents and get everything together to send out on Monday, but they will receive the evaluation today.
Okay, so then I'll
Mhm.
go ahead and put together some of my best articles and have everybody look out for that email, ones that are kind of most up to date, easiest to read, most comprehensive. Um, I'll go ahead and put together some of my favorites.
Okay. And just to reiterate, everyone, on Monday, we will be sending you additional references from today's presentation, and a full copy of the slides. Today, you will receive the evaluation to be completed via email once we conclude today's presentation. I know some people would like to follow up with Brittany separately for additional information and talks. Her information will be provided in the email that will be sent on Monday for you to contact her regarding any additional information that you would like to receive from her. Um, and if there aren't any additional questions, we will go ahead and conclude the webinar at this time. Thank you so much, Brittany. We truly appreciate your time and your expertise with sharing the information today. And thank you to all of our attendees for being able to attend this webinar and receive the information shared from Ms. Davis. Everyone, enjoy your evening. Thank you once again from NC.
Thank you all for tuning in.